Okay, so now we're going to discuss inflammation, and we're going to talk about a few diseases. As we discuss this, we'll focus on tuberculosis and talk a little bit about hepatitis B as an example for our virus infection. And so for inflammation is commonly thought in alignment with infections. And causes of inflammation can be burns, cuts, or infections. So inflammation in general is just simply defined as a redness, swelling, and pain. And from a histologic, it's going to be edema, and it's going to be white blood cell tissue infiltration. And of course, as we know, is that when you have an inflamed tissue, the endothelial cells become more leaky, so they separate so that the white blood cells can do their diapedesis and get into the inflamed tissue. And at the same time, red blood cells will also get in, and so that's going to bring in the redness. The edema is going to bring in the swelling in the area. And then anytime you bring in swelling in a confined space, it's going to lead, of course, to pain, pressure, that kind of thing. And so here we have an infection, and the infection will lead to initially an acute stage of the infection. So we'll have acute inflammation, and we're going to have what we've already been talking about, an innate response, an adaptive response. And these are going to have the same players we've been talking about, our neutrophils, interferons, etc. Now, what we want is we want the infection to be cleared. So if it's an acute disease, it's going to be cleared. Alternatively, it could also lead to death. So death is always going to be a possibility regardless of the type of infection. And the reason for death can be multifactorial, so we're not going to go into all of that right now, but just note that an acute infection, you cannot survive with a chronically infected with a virus or a bacterium that is acute. You need to get rid of it or you're going to die. Now, there are some infections, though, that we can't clear. So infections that can't be cleared are going to move into a stage of chronic inflammation. In the case of a chronic type of disease, again, you have always the possibility of death. So that is always going to be a possibility. And you can also move into a state where you have the infection under control to some level. So these would be infections like tuberculosis, hepatitis B, and schistosomiasis. If you go to a chronic phase in any of these diseases, you don't clear the infection. The infection is still in your body, but your immune system is able to keep it in check. And then in all of these diseases, you can have points of reactivation. And that can lead to, of course, two outcomes: death, or you go back to a chronic inflammation state and you can go back to suppression, or you can go to death. And so all these are going to be intertwined. Now, let's just talk about some of our potential outcomes. So we have here an intracellular pathogen. And so our intracellular pathogens are, of course, going to require our Th1. And we can have an acute infection, such as influenza. So influenza, so we have our intracellular. And this is going to be influenza. And so this is acute, always acute, never chronic. And so you have two outcomes. You have clearance, and alternatively, you have death. So that's all you can have with influenza. You cannot become chronically infected with a respiratory virus. And that's the same thing with our COVID-19 virus. It's the same thing with our RSV virus, respiratory syncytial virus. You have to get rid of those viruses. Now, intracellular pathogens, another virus is going to be hepatitis B. So we have Hep B. Hep B. And Hep B is going to have an acute phase. And Hep B, you can get clearance. Or you can get a chronic, or you can also die. Okay, and the chronic can also lead to death as well, of course. And so Hep B is a virus that you can live with. It's not like flu, and it's because of location. It's in your liver. And as we know, your liver can take a lot of hits. The liver is able to regenerate itself. It's a very large organ, and it can withstand a chronic type of an infection, whereas your lungs, respiratory tract cannot. And so that's why influenza can never go chronic, but Hep B can go chronic. And then another intracellular pathogen is Mycobacterium tuberculosis. And of course, you will also have an acute phase. And in this case, you are going to go chronic. It can also lead to death. Most people, though, go to a chronic phase. And so death is oftentimes associated with an underlying condition. And any of these respiratory infections, a lot of them have underlying conditions associated with higher mortality rates, which makes sense because if your lungs are already compromised and you bring in an infection, it's going to become even more compromised. And then we have our surface pathogens. Oops, sorry about that. So these are our big guys. These are our worm type of infections. And so we have a gut worm. And you will have an acute infection. And these are going to be more Th2, whereas the intracellular, of course, are Th1. The gut worm is going to require Th2, so that's your mast cells, your eosinophil story, and then you're going to get clearance. And then you're going to have schistosomiasis. Another parasite, so you're going to have an acute stage. And then this, of course, goes chronic as well. And so just like anything, you can have this go towards death. Typically, an acute infection will not lead to death. So I'll put a little dotted line, unless, again, you have some underlying condition. And I should do the dotted line, I guess, for myco, because mycobacterium, your body is, if it's healthy, it is able to at least keep the bacterium in check. And it's when you become suppressed or immune compromised in some way that you have troubles with these. And then we have our extracellular pathogens. And these are our bacteria primarily. Could be fungal infections. Fungus infections typically only are going to be a problem for someone who's immune compromised. We are exposed to spores and fungi everywhere, and our immune system does great against controlling them. And so here we'll have a staph infection. This could be a strep infection. It could be Haemophilus influenza, which is a bacteria infection, Neisseria, gonorrhea, Neisseria, meningitis, etc. All extracellular bacteria. And then this is also going to have an acute phase. And this is going to lead to clearance. Or, of course, we can also lead to death. Now, you cannot live with an extracellular bacteria growing inside of your body because the purpose of the bacteria is to break down your cells in order to get nutrients. And so you will lose loss of organ function. And so that's going to kind of what happens when staph gets into your lungs, for example. It's going to break down your lung tissue, and you cannot survive with that. So you have to clear it, and unfortunately, sometimes this can lead to death. Extracellular are going to be your Th17s. Okay, so here is again a table. This is from your book, and so this is talking about the different types of immune cells that are going to be important in these three different categories that we just discussed. So for your intracellular pathogens, for example, you are going to have your innate, which is what we talked about. This is going to generate a Th1 environment, and your Th1 cytokines are IL-12 and interferon gamma. And then for our surface, our parasites, we are going to have our innate mast cells and eosinophils. They generate a Th2 environment, and our cytokines are IL-4 and IL-5 for the Th2 environment. Our extracellular pathogens, these are going to have neutrophils and complement. Also, antibodies can play a role, macrophages as well, of course. This is going to drive a Th17, not as inflammatory as a Th1. CD8 T cells are not involved, and NK cells are not involved because they have no ability to recognize an extracellular bacterium or pathogen. IL-17 is the cytokine that is involved to help drive that. All right, so let's talk a little bit about tuberculosis. So tuberculosis is going to be a pathogen that creates a chronic infection. And so in the United States, we are very big about testing for the presence of tuberculosis to prevent spread. So people who have active tuberculosis are able to spread the virus. So here is just showing a few tests that are used in order to determine if somebody is infected with tuberculosis. Now everyone is really familiar with our skin test, which is shown here. So this is our TB skin test. This is also called the Mantoux test or the Heath test. And so basically, this is kind of how it works. You basically are going to be exposed to the antigen, and the antigen is typically going to be injected into your arm. And so what happens in this kind of test is you have these little tuberculin particles, which are these, oops, sorry, I shouldn't have done that. Let me go back to this. These little yellow things that are pointed out here. And so these little yellow things are going to be injected into your skin, dermis. They're going to be picked up by your tissue-resident macrophages. Your tissue-resident macrophages are going to get activated because these are going to activate toll-like receptors, for example, and they're going to release your cytokines. Your cytokines are going to do what we know cytokines do. They're going to activate your endothelial cells, going to become inflamed, sticky fingers, and then your neutrophils are going to come along, or other white blood cells are going to come along, other macrophages come along, and they're going to diapedese and go to the skin. At the same time, you have your tissue-resident dendritic cell, and your tissue-resident dendritic cell will pick up let me make this yellow, will pick up the tuberculin proteins, will bring it to the draining lymph node and present it to the T cells. Now, if you have ever been exposed to tuberculosis, or if you've been vaccinated against tuberculosis with a BCG vaccine that's used in many countries, not the United States, then you will have memory CD4 T cells. These memory CD4 T cells will divide, and then these memory CD4 T cells will go to the site and where they will participate in the helper function that they do with the macrophages that are present, and you will get inflammation. And the result is that you will have a red spot, and that will be a positive tuberculin skin test. Now, one of the things about this TB skin test, it cannot differentiate between your infection or vaccination. In addition, it cannot tell if a person has active TB or has suppressed TB is under control. And so this just gives you a yes, no, this person has seen the tuberculin bacterium, or no, they have not. So it doesn't give you any functional useful data as to the state of the actual patient. There is another test, and this is a little bit more involved, but it can give you a little bit better information. There's the Heuer test. And so this is going to screen for TB activity. So it's looking at the immune function. And the readout is going to be interferon gamma. So you're basically going to take the patient's blood and you're going to add to it bacteria peptides. Now notice I say peptides, not proteins, because you're trying to see if the T cells will react. And so if you have a patient exposed to the bacterium, then your Th1 cells will produce interferon gamma, which is what's happening on the top. If you have a patient that has not been exposed, your T cells will not be producing interferon gamma, which is being shown on the bottom. So your T cells, if they're not in a memory state in this type of assay, will not produce interferon gamma to the peptides being added. They're just not there in high enough number, and they have never seen peptide before, so they don't get activated. So that's the Heuer test. If you are positive for a tuberculin test, oftentimes you also will get a chest radiograph. So a chest radiograph is going to show whether or not you have a granuloma type of, or a spot in your lungs. And so here you can see that, that's not very good. Let's go here. Here you can see that you have an opaqueness in the upper zone of the left lung. Let's see. Okay, and so this would be if you had a positive skin test or a positive Heuer test, and you have this image of your lungs from a chest radiograph, then that would be a clear indication that somebody has tuberculosis, or, not surprising or not surprising, the vaccine. The vaccine will not create this large of a lesion in your lung. Vaccine, though, is chronic, and we'll talk more about that when we talk about vaccines. Now, just to note that this chest radiograph and the cultures and the skin test are not sensitive, or are not sensitive to early TB. And so you must rely on immune tests for this. One thing you cannot measure is antibodies, because, there we go, okay. But not antibodies. There are various mycobacteriums in the environment, and they're non-infectious to us. And so many people have what are called cross-reactive antibodies. So you might test positive for a mycobacterium antibody, but never have been exposed to actually Mycobacterium tuberculosis. You were exposed to another type of mycobacteria. And so the you have to rely on something like the Hoover test, which is the test for T cells, not antibodies. And T cells tend to come up fast anyways, and so they would be good to look at acute types of infections. Now just keep in mind that the skin test, which is the most prevalently used, is what's referred to as a delayed hypersensitivity reaction. Now we talked about immediate hypersensitivity reaction, and that was IgE mediated. So a delayed type hypersensitivity reaction is not an allergic reaction. This is mediated actually by your CD4 T cells and macrophages. And so it's given delayed because it takes about 2 to 3 days in order for you to get this bump, this inflammation, not the immediate IgE response, which takes minutes to hours. Okay, so let's talk a little bit about cytokines. So we have with our cytokines a series that are going to initially get activated, and then they're going to sort of set the stage for the ensuing immune response. And so first we have, of course, our alarm system. And hopefully by now you understand that this is generally going to be our macrophage. Now, our macrophage has a few things that it's going to want to do. It's going to want to release our cytokines for our acute phase. And so those are going to be, of course, our IL-6, our IL-1, and our TNF alpha. And so they're also going to release GM-CSF. Granulocyte monocyte colony stimulating factor, and that's going to increase neutrophil production. Remember, after inflammation, neutrophils production actually increases. Not only do they get released, but they actually are going to be increasing. The macrophage will also release IL-8, and this is a NEUT recruitment. The macrophage will also be releasing IL-12 for an intracellular pathogen. So we'll say we have an intracellular. And so IL-12 is a Th1 cytokine. But note that the IL-12 is not made by a Th1 cell. T cells do not make IL-12. That comes from your macrophage. Now let's talk a little bit about what's going on with these cytokines even more so. So we know that we have our acute phase, but they also have other functions. So IL-1 is also going to be an activator of T cells, so it's a general activator of T cells. Interferon alpha is going to increase diapedesis. And of course, all of these fall into the acute phase, and this is going to lead to fever, increase of liver, etc., what we've already talked about. IL-12 is going to activate your natural killer cells. Natural killer cells are going to make interferon gamma. And so the IL-12 plus the interferon gamma together are going to drive a Th1 response. Now your Th1 cells are going to, of course, be activated by your dendritic cells. I'm not going to put that in here, but we'll eventually have a CD4 Oops. And the CD4 T cell is going to make TNF alpha. Oops. And it's also going to make interferon gamma. So while a T cell cannot make IL-12, similar to an actual killer cell, a T cell can make interferon gamma. And you're going to have, of course, still your NK cells making interferon gamma. And you're going to have your TNF from your macrophage. And if you have too much TNF, you can have tissue damage. Now for interferon gamma has several functions. Interferon gamma is going to increase MHC expression, 1, and is going to increase antigen processing. It's going to increase macrophage maturation. Remember, macrophages are hanging out in tissues. They're not always in tune with an infection. They're there also for homeostasis. So they oftentimes need help in order to get activated properly. It's going to increase NK activity. It's going to have the opposite of decreasing Th2 cells. And it's going to increase antiviral effects. Such as interferon 1. So interferon gamma is known as IFN2, type 2. And just as a note, interferon alpha or beta are IFN1. Okay, so interferon gamma is always IFN2. It's also called interferon gamma. Now, what's important about this is that this is all about an intracellular pathogen. And so Mycobacterium is able to cause an overt type of disease if a Th1 is not favored. And that's true with all intracellular. So So we have conditions that do not favor Th1. And these can be that you have mutations in the cytokines that set up this. So you can have mutations in IL-12, IL-12 receptor, or interferon gamma. And so if you lose those cytokines, you're not going to get that Th1 environment. You're going to get skewed more to a Th2, which cannot control an intracellular pathogen, and that could lead to potentially death. Second is that your cytokine network is disrupted by drugs. One common one is anti-TNF alpha. Here, draw this a different way. So TNF alpha is a Th1 type of cytokine. It's made in different conditions too, not just Th1, so it's not specific for that. But in rheumatoid arthritis, TNF alpha is elevated, so oftentimes patients with rheumatoid arthritis are treated with anti-TNF alpha. And rheumatoid arthritis, of course, in an aging population is increased. So what you typically get is a complication is atypical Mycobacterium infection. and there's more of a chance to lose control of the infection. And then, of course, a third way that you cannot favor a Th1 response is if you have trouble with your CD4s in generating that response. So during an HIV infection, you have a loss of CD4 T cells. So you have a loss of Th1. And this is one of the reasons why people who are infected with HIV have trouble, and especially untreated or unmanaged, will have trouble with mycobacterium, because it doesn't just have to be mycobacterium tuberculosis, it can be mycobacterium leprae, and they will have trouble controlling that infection and potentially can lead to death. Okay, so just keep all those cytokines in mind as we start going through all this. Keep in mind also that you have this whole idea of Th1 versus Th2 versus Th17. And all of those require an environment set up in order to make sure that you get the right response for the right pathogen. So you have a Th1 loop, for example, which we kind of just discussed, in which you have IL-12 made by the macrophage and interferon gamma made by the NK cell, and you have interferon gamma made by the Th1 and the CD8, the Th1 cell, the CD8 cell making interferon gamma TNF, and all of these together are simply amplifying the environment for Th1 to make sure that you maintain that Th1 environment. Some things to keep in mind with respect to Mycobacterium tuberculosis is that you are going to have an intracellular bacteria, and one of your arsenal gets completely eliminated. So keep in mind for Mycobacterium tuberculosis, antibodies are not helpful. Basically, Mycobacterium tuberculosis has virulence factors which they get inside of a macrophage, and they're able to live inside of a phagosome. And so the macrophage cannot eliminate the bacterium. And they cause multinucleated giant cells to form because of the Th1 CD4 cells will release interferon gamma, and it causes the multinucleated giant cells. They basically fuse. So you have many macrophages that fuse together, and they have lots of nuclei in them. And so you have a type of sore or something you think about in your tissue, your lung tissue, shown here, and it's called a granuloma. That doesn't really show up. And your granuloma is hallmarked with macrophages in the center. So you have our macrophages making this ring, these guys here. And you have on the outside, you have Th1 CD4 T cells, and they're releasing interferon gamma. They're trying to help the macrophages identify the bacterium inside of them so they can kill them. But the bacterium prevents the lysosome enzyme, so it's able to survive inside of the endocytic compartment. So even though the macrophage is getting help from the T helper cell, it's still not able to get rid of the bacterium. And then you have in the middle, you have necrosis. Let me color that different. That's important. So you have a period of necrosis in the middle, and it gives sort of like, it looks like cottage cheese. So the necrosis looks like little holes. So you have a cheese-like morphology, which is a hallmark of Mycobacterium tuberculosis. Now, also keep in mind that these necrotic centers in patients with active TB are what the patient is actually coughing up, and they're filled with the bacterium, and so that's what is actually spreading the bacterium. Now, Mycobacterium tuberculosis is going to activate your macrophages through TLR2 and 4. Oops. And these are what are going to see lipoproteins and polysaccharide. The macrophage then will release IL-12. And it also is going to release nitric oxide. Most people are going to have a primary TB that goes latent. And latency is basically the CD4 T cell macrophages are able to keep the bacteria in check so it can't overgrow. Latency can lead to reactivation. And reactivation can go back to primary or myelary TB, which means you have dissemination and widespread infection. Dissemination means that the bacterium gets into the blood and it moves throughout the whole entire body. In a primary, usually it gets contained. In myelary, it's harder to contain, and usually that's associated with some sort of underlying condition, whether it's HIV, immune suppressive drugs, cancer, or something else. There's something else driving that. Now, Mycobacterium has virulence factors. And virulence factors are factors that pathogens have that help it to overcome our defenses. And so it has a waxy coat, glycolic acid. Oops. And this helps it to be hard to phagocytize. But our phagocytic cells eventually do eat it. It also has the ability to live in a phagosome. And it's secreting catalase. So it prevents the oxidative burst. Which is, of course, very important for our phagocytic cells in order to kill what's inside of it. So basically, they form a granuloma, and the granuloma is not going to kill the bacterium, but it's going to keep the bacterium in check. And again, reactivation can occur when you have some sort of immune suppression, such as HIV. Okay, so let's talk a little bit now about hepatitis B. Hepatitis B is going to be a virus infection, another intracellular pathogen. So you do need to have a Th1 response. Hepatitis B is sensitive to interferon. Mycobacterium tuberculosis is not sensitive to interferon. So Th1 is key for our hepatitis B. And we have our hepatitis B is going to be a virus that's going to infect your actual hepatocytes. Many people can clear this infection without any problems, but some people are unable to clear the infection, and the virus goes chronic. A lot of the pathology associated with hepatitis B is caused by your immune system attacking your hepatocytes for the Th1 response. So one of the key things is that associated with chronic hepatitis B is going to be corticosteroid usage and malnutrition. And hepatitis B is when you have a hepatitis B infection of the liver, your antibodies are not going to, similar to mycobacterium tuberculosis, have much of a role. And so what you really want for mycobacterium tuberculosis is you want a vaccine. I'm sorry, for hepatitis B. Hepatitis B, we do have a vaccine. It requires several shots given over a period of months. And the vaccine is going to be a protein-based vaccine, and it's going to induce antibodies. And the antibodies are going to neutralize the virus. So why that's important is because if you have neutralizing antibodies, you can prevent disease. So your antibodies are in essence sort of mopping up the virus before they're able to infect the hepatocytes. Some will get through and probably infect because there's nothing called without sterilizing immunity. However, your immune system is able to control the small amount of virus that gets in and is able to eliminate it so you don't get the disease. That's the whole purpose of vaccinations is to prevent the disease. And so if you don't have the vaccine, you get infected, you don't have those antibodies, and so you're basically, the virus is able to infect too many hepatocytes, and your immune system is going to kill too many of them and potentially do a lot of damage. Again, most are going to clear infection. Unless you have too much virus in the inoculum. And again, that's where the vaccine comes in to decrease that number. Or you're exposed at an early age. This has been linked to tolerance to Hep B. And so you have the wrong immune response. You're going to have a Th2 instead of a Th1 response. If you are chronic, you can get reactivation. And similar to our mycobacterium story, this is usually in immune compromised. And so we have here again our Th1 response. Th1 plus IFN gamma. Oops, I did that right. IFN. CD8 equals destruction of your tissue. And this is what can lead to cirrhosis. Or hepatitis, which would come before cirrhosis. And so it's important, again, to get vaccinated because then you avoid overwhelming your immune system, having your immune system overactivated so it destroys your liver tissue. Okay, so again, your viruses and bacteria can infect you and do damage, but it's also your immune system can do damage as well. So the immune response can have negative effects. However, as you know, we can't survive with most pathogens. So your immune system is trying to clear a pathogen at the same time doing damage. Sometimes for a chronic pathogen, the immune system has to make a choice. Am I going to keep pushing and trying to eliminate this, or am I going to hold back and just keep it in check, which is what it does for tuberculosis, for example. So some cytokines have some negative effects just in general. So our TNF is going to cause weight loss. We have our excessive granulomas, so we have our interferon gamma, and TB causes granulomas. And in open TB, you have necrotic tissue in the center of the granuloma. And this is due to a lack of oxygen. Basically, the macrophages in the center don't get oxygen, so they die, but they're loaded with tuberculosis. And then you cough this up, and this is going to spread the infection. We also have, with respect to Th1 cytokines, so this is Th1 and this is Th1 with Hep B, is you're going to have fibrosis plus cirrhosis of the liver. And again, it's type 1 inflammation is very strong and it does a lot of damage, but it's necessary for intracellular pathogens to get rid of them, and it's because you need those CD8 T cells. Your CD8 T cells are excellent at getting rid of intracellular pathogens, but unfortunately they kill the cell too. And if there's too many cells infected, then the CD8 T cell is going to kill all those cells, and that's going to do damage to your actual tissues. So it's important to get vaccines for these intracellular pathogens. That's why we have so many vaccines against viruses, because you don't want your CD8 T cells to kill too much of your actual tissue when they're trying to eliminate the virus pathogen. Okay, so that's the end of that lecture.